Okay, good afternoon. Sorry about the little bit delay. I have problems saving my presentation in the USB port. Okay. Well, thanks to Dr. Shah, who changed the format of the imaging conference. I had to prepare almost a brand new lecture. Can recycle, which is good, Otherwise you get bored, right? Especially for the older fellow, senior fellow, I should say. Okay. So, today we're going to talk about coronary CT, cardiac CT, mostly CTA with contrast for assessment of anatomy and physiology. Well, this talk would have been impossible, 10 years ago, even 5 years ago, because the recent technological advances and amazingly large amount of data was generated with CT is unprecedented, meaning that no other non-invasive cardiac imaging has amassed such amount of data in such a short period of time, like CTA, okay? So we gotta keep up with it. And the reason is really, like it or not, this is really amazing technology, allows us to see a lot of things that we weren't even imagine when I was in medical school, not even when I was in fellowship. I take it for granted right now, but bottom line is CTA is a very powerful anatomic technique who allows you to look at the lumen stenosis, can do the plaque imaging, functional analysis, myocardial assessment, CTFFR valve structure. Some of them CT does very well. Some of them has a secondary or tertiary role because other technology can do it better. But regardless, we're going to talk about labor strength and limitation and how the CTA can help us manage the patient, especially when CT is good enough with anatomy only, okay, which quite a few, I'll say, depending on the patient that you image, you can have a very good success rate in deciding when anatomy is enough, okay? And we're going to obviously talk about when the anatomy is not enough, we need functional information. And the key here is, do we need order another test, or with the CTA is good enough? And if I have time, we can talk about other value of CTA. Okay, this is the brand new European Society of Cardiology guideline for assessment of chronic coronary syndrome. Essentially, people who show up with suspected coronary disease, typical patient with chest pain or angina equivalent. As you can see here right now, essentially coronary CTA and non-invasive testing, I place it as equal, if not more emphasis, in terms of using CTA as a first test of choice for assessment of this patient, okay? So basically for the new guideline, any patient who has low clinical pretest likelihood or even moderate, and obviously patient you think you can get a good images and you have local expertise, and you can assess the atherosclerosis burden, which is we're going to talk about, is very important. And essentially, stress test for the European guideline is mostly they don't even mention intermediate pretest likelihood. Okay, stress test is indicated for people with high pretest likelihood or high clinical likelihood, they call it, obviously, and mostly reserved for patients who already have diagnosed disease. It's just interesting here, there's no way mentioned where the patient with intermediate clinical likelihood. But, so anyway, but this is not surprising because, you know, even 3 years ago, the UK National Institute of Health and Care Excellence, which you know the British are very cost conscientious, and they don't, usually they base on their recommendation on rigorous evidence-based medicine, which in this case, a lot of people accuse them to take too far in terms of leap of evidence. Even 3 years ago, they recommend CTA as a first line a test in patients with suspected CAD, and this essentially took away tremor ECG as a test to assess a patient with chest pain, and estimated can save almost, I guess, $20 million every year in UK. Might not sound a lot of money, but here in the US, if this applied to US, the money could be much more. So the point is some of the prominent cardiology, like Dr. Blaha from Johns Hopkins, have this editorial about coronary CTA and new unstable patient. It's time for US guidelines to get to be nicer. So what leads to all these Europeans and British to change their approach in assessment of patients with suspected CAD? Number one is no surprising. CTA is an anatomical technique. It is going to be much more accurate when you compare to invasive angiogram. That's not surprising, right? Compared to any functional stress test. I hope you don't need me to explain the reason why. But regardless, the key here is if you have a normal or minimal disease in the coronary CTA, most likely you will not have significant coronary stenosis. That's really the major strength of CT, okay? So in addition to have a very good anatomical depiction of coronary stenosis, over the last 5-10 years, there's several randomized studies using CTA versus standard of care in management of disease, a patient with suspected CAD, like PROMISE, Scott Hart, essentially shows that there's a trend that if you use CTA as the first test of choice, there might be a reduction of clinical event, okay? It's small, subtle, but if you combine all the studies together, there's some meta-analysis, which is not the best. There definitely is a trend, but bottom line is, there's no question is CTA is as good as any other non-invasive functional testing as the first line of testing in terms of patient's outcome, okay? And we have so much more data now, we can even say the warranty period of coronary CTAs, or normal coronary CTA, is over 8 to 10 years. It's not surprising. We know the patient who has calcium score 0, the warranty period is probably more than 10 years. So this is not surprising. And I think the most important thing people forget to mention is the technological advances that we achieved for the last, I would say, 5 years is tremendous for fellows who have been here a bit longer. You know, I would say 80% of the time, you can achieve high quality images with very low radiation compared to SPEG or PET. I think it's very comparable, okay? As you can see there, it is over the last 10 years, this multinational registry has shown the 80% reduction of doses. Obviously, we were using a lot of radiation, but right now, the average radiation dose is about 5 millisievert for coronary CTA. In our lab, depending on the type of patient, I think we are pretty close to that number. But remember what I mentioned about the CTA as the first line testing could lead to probably reduction of clinical event. A test doesn't cure coronary disease or decrease the event rate. So what you do is information, correct? And the main reason is CTA give you atherosclerosis information, okay? This is one of the 2 cases that we wrote for JACC imaging 5 years ago. In 2 patients, both in dialysis, both of them had perfectly normal myocardial perfusion imaging spec, normal EM, normal size. You can see the one in the left-hand side is a 42-year-old guy with all the risk factors, been dialysis for 3 or 4 years, and his perfusion is normal. He has no calcium, and 4 years after the follow-up, he's still doing very well, still in dialysis. Because the other guy was 50 years old, similar risk factors, been in dialysis a little bit longer. The calcium score is over 1,000, and I think 3 years after a normal myocardial perfusion imaging, he had an event rate. So it's kind of, we know that a normal myocardial perfusion imaging, the warranty period really depends on what your underlying atherosclerosis burden. So same principle applies to CTA. So this is, I think, a very well-done analysis for Scott Hart's study, where it's probably one of the first, it's actually the only randomized study that shows CTA improve outcome, quote unquote, compared to standard care, which mostly stress, tremor, ECG. Nevertheless, they offer some insight how or why CTA approach is associated with likely better clinical outcome. And not surprising, there was significant changes in the medical treatment in this patient. As you can see, a lot more patient in red line, patient assigned to CT, and the blue line to conventional standard care. A lot more patient, well, a lot. I mean, you can see that it's truly only about 10, 15%. But in terms of odds ratio, it's significant. More patient was put in antiplatelet therapy and lipid-lowering therapy, okay? So they went back to look at, in the average time from the time of the testing to the change of therapy is about 50 days. So they went back and looked at the event rate in the right-hand side of this image right here. You can see this is without counting those 50 days. So basically, the first 50 days, basically the event rate is about the same. After the 50 days, the curve starts separating and probably continue separating afterward. And this is excluding those 50 days, meaning that really the test doesn't really change the prognosis. It's really what we do with the test information to change the outcome of the patient. All this is kind of common sense. But I think it's nice to prove the point that I think going back to these 2 cases here is nowadays, I think for any functional test you do, regardless of debate of anatomy versus physiology, you need to know your atherosclerosis burden. So essentially, like, hopefully, like Dr. Harvey Heck say, you know, when you go through the airport, with the X-ray screening, and ideally, someday they, you know, after you go through, they give you a little piece of paper saying what your calcium score is. I think that would be, so, okay. So those are general management, right? I mean, but how about individual patient, right? Let's say if you have the clinical, when you see a patient, what's the question you ask? Someone coming with chest pain, engine equivalent, does the patient have coronary disease? We talk about, right? Even you have a normal treadmill, normal nuclear, normal PET, normal stress echo, well, sure. Do you have coronary disease or not? And then if you have coronary disease, how bad, what's the extent, and then you want to know what to do. So on the left-hand side, this is actually one of the first cases we did with our force scanner. I think he's a very skinny patient. He got about less than 1 millisievert radiation. Normal coronary disease, no disease, no plaque whatsoever. Like Dr. Mamaran said, this person is almost immortal. Not only from the cardiac standpoint, there's more data showing that if you don't have coronary disease whatsoever, you're much less likely to die from other non-cardiac conditions. It's basically the marker of, you're lucky, essentially, right? You're born. And the one in the right, there's minimal disease, but it's disease. It doesn't need to have revascularization, but probably obviously need optimal medical management. In the right-hand side, obviously the patient with significant extensive disease, you need optimal medical therapy, plus minor revascularization, depending. Okay, and this is, again, it's not surprising to you guys. This is a very interesting study done, I think, in Denmark, I believe, right, where a patient underwent CTA, SPECT, and PET, and invasive angiogram with invasive FFR. So they got very good information. Essentially, the limitation of CTA has very poor, or not very good positive predictive value compared to SPECT and PET, meaning that if you have disease, usually calcium burden makes the assessment of functional analysis a lot more difficult. But oftentimes, you don't really need other functional tests, for instance, to see if the lesion that you see in the coronary CTA is significant or not. Let's say if you have critical disease, subtotal total occlusion, those are highly specific, over 90%, 95% specific. Patient is going to have reduced invasive FFR. So you have serious lesion like this, patient has symptom, there's no need to do any more testing. Patient probably, depending on the location of the disease and the symptom, you can decide the patient either go to angiogram or just need medical therapy. Okay, so you have critical stenosis, subtotal total occlusion, there's no need to do more testing. Or if you see some aftermath or sequela of coronary event like calcification, there's a signs of very old myocardial infarction, lipid fat replacement, like you can see here, even in non-contrast study, you can see that. Obviously, an aneurysm, a VSD, or a wall motion abnormality. So you see that even if LAD is heavily calcified, you see apical wall motion abnormality with a clot in there in one of those cases right here. I mean, most likely that vessel is diseased. The patient need to go to either have a viability assessment or ischemic assessment. But there's no question that lesion is significant. But I think we're talking about most of the time like lesion like this, right? I mean, so what do you make out of this? And this is not uncommon, especially with the aging population. We're going to see more and more of this patient. So how do we assess functional assessment? How do we assess the functional significant stenosis? Well, CT, we can do CT myocardial perfusion. Essentially, very similar in a sense of display, like MR perfusion in a sense. A little bit different. The different approach to doing CT perfusion. Essentially, you need to do a resting CT, okay, and a stress CT. Essentially, patient needs to have 2 CT scans. This is very important, all right? It's just like nuclear. You need to have a resting scan and post and stress scan, and you compare basically the contrast intensity in the myocardium to decide the patient has a perfusion defect or not, okay? Same thing with MRI perfusion. You can do dynamic perfusion and track the contrast, wash in and wash out, and you can have time intensity curve, as you see here, okay? And you can technically calculate flow reserve, technically. This obviously is not done routinely. Still, I don't think that many not many centers in this country is doing it. We haven't done a proper CT perfusion imaging, but this is similar protocol we've done for other type of condition, but this will be a similar protocol. In this case, it's a patient with PD, a PDA right there, okay? So this is what it will look like, and you can have a parametric display, just like nuclear, the polar map in terms of perfusion. So this is using a Siemens scanner, which use a shutter mode, but I think the best scanner, personally, I think, for CT perfusion is probably those with white detector scanner like Toshiba or Canon and GE, because the detector is so big, it covers the entire heart in single rotation. You can have uniform assessment without any delay of the whole myocardium. And there's quite a few, essentially the similar principle right there. And there's been quite a few studies. This has been, people have been doing this since the advent of CTA. This is one of the first studies published 6 years ago. So this was done, essentially shows that, using invasive FFR, the gold standard dynamic myocardial perfusion imaging has very good diagnostic accuracy. I'm not going to go through that too much. And there's some even large randomized multi-center trial using CT perfusion compared to, in this case, invasive angiogram plus SPECT. This is a little bit unusual design because most of the people use invasive FFR as gold standard right now. And this is one of the paper published again several years ago compared to CT perfusion versus MR perfusion. Very similar principle, as you can see there. The key here is the following. CT perfusion alone is very good, but it's a little bit, in terms of, if you look at CT perfusion alone, the sensitivity is not as good as MR perfusion, 68% versus 80-some%. If you add the CTA here plus the CT perfusion, and that's the main advantage of CT perfusion. Basically, you have the narrow anatomical information, allows you to add more accuracy to your functional perfusion information. So, but the problem is obviously you need to have 2 scans. You need to give patient adenosine a stressor. So it's not very efficient, and it's always you're adding more radiation because you're doing 2 scans. But you can do a dynamic CT perfusion scan with the order around 6 to 8. I would say average 8 to 10 receiver, which is comparable to 2 days or rest stress SPECT myocardial perfusion imaging. But the real, I think I would say excitement, but one of the major breakthrough was this when this technology called CT-derived FFR was described almost 10 years ago, and what's attractive about this CT-derived FFR is you don't need to do a stress imaging. So you can just do your routine CT, and you can derive FFR from the CTA information, okay? So there's several ways of doing this. Two has been described so far. The predominant one that we use so far clinically that we all know with the heart flow is the method of computational fluid dynamic. So essentially, what it does is, since CT gives you a very good anatomical description of the coronary artery tree, basically construct a 3D model of aortic root and the coronary arteries up to third order branching, usually 1.5 millimeter vessel. And then you construct a mesh with multiple points to compute the pressure and flow, including branch point, right? The physiological model of coronary circulation with specific inflow and outflow condition depends on the coronary and the myocardial mass, which you can get it from CT, okay? And from experimental study, we know what's the average coronary flow response to stress, so that's also can be modeled. So basically, you model the resting perfusion and the maximal hyperemia depending on the mass and expected resistance. And then they dump all this data into a computer algorithm, and they give you a CT-derived FFR, okay? Again, that's the dominant one that we use clinically. It's been approved by FDA, but the other way of doing it, in this case, called machine learning. This is a little bit different. This is, they essentially construct the algorithm not using patient's data, but rather using what we call models of a phantom, you know, with different diameter of the tube, with different, can model different stenosis. Essentially, you put doing a lot of this, and machines keep running, and you can model it. Obviously, I have no idea how they do it mathematically, but essentially, they can also come out with FFR based on CT scan. But this is, I think there's some publication showing that's promising, but I don't see this will ever reach commercial because of the heart flow is quite aggressive in making sure this doesn't reach the market, I think. Anyway, this is a example of a CT-derived FFR. It's a case. We've done a couple hundred cases. I couldn't make them to give me the data. Otherwise, I was going to share with you what we have. But essentially, you have the coronary CTA, and then they construct a 3D tree, essentially at different level of coronary artery. It show you the derived FFR, and you can superimpose to a 3D model to give you some idea of the functional significance of this lesion. I mean, the potential clinical impact depending on the location and significance. So it's for you very important to understand, because people tend to think CT-FFR is FFR, but by no means CT-FFR is the same as invasive FFR. You can see right here, for all the studies being published, compared to invasive FFR, I mean, the accuracy is about 80%, 85%. Okay, if you think about, if you compare to PEDs, MR perfusion, I mean, the number is about in the same ballpark, okay? So it's not, so I want you to make sure you get out of here knowing that CT-FFR, or FFR derived by CT, is not the same as invasive FFR, okay? Okay, so this is some examples. This is a patient of us, calcium score, I think, of course, Dr. Attar's patient with a calcium score over 1,000. I think this guy is 90-some years old, but he insisted. Patient has some vague symptom, he doesn't want to cath the patient. And I throw it here just to show you that not all the patients with high calcium score, CTA is prohibited. It really depends on distribution. And as you can see here, I mean, patient has mostly eccentric calcification and kind of basically it's only vessel who is quote to be significant by CTFR, one of the branches at OM, but you can see that there's no significant stenosis in the left main, no significant stenosis at LAD, which essentially for clinical management, someone who's 90 years old, that's good enough. I mean, the patient doesn't need any revascularization. All you have to do is intensive medical therapy. Okay. And HeartFlow has been very good in funding a lot of clinical studies showing the clinical utility of using FFR derived by CT on top of CTA as a management strategy. This is a platform study presented probably several years ago. Basically, patient planning to go to invasive cath. So the clinician already made the decision of sending the patient to the cath lab. And obviously 100% the patient who randomized to usual care got a cath. And what happened is if you do a CT-FFR in those patients, okay, only 40% of the patient end up going to the cath. So essentially eliminate 60% supposedly of cath, okay? So, and what happened is with the usual care, 80%, 73% of the patient who went to cath lab did not have significant stenosis. We kind of know that 60 to 70% of the patients who go to cath lab do not have significant stenosis. And only 12% of the patients who went to have a CT-FFR went to the cath lab has no significant disease. So you can see you're really doing less cath and it's at a higher yield, basically. We might say, well, what happens to the outcome? Maybe you're not cathing the patient, they need to be cathed. But essentially, even the patient with, so essentially if you have CT-FFR was normal, the event rate in 1 year is very low compared to a patient with abnormal CT-FFR. So appears to be safe. This we already talked about. Increase the cath lab efficiency. The efficiency of cath lab using FFR approach is about 70%, with the usual cath only 30%. This is across multiple studies. So this is one thing that probably no one could argue, that if you have a CTA, you do a FFR derived from CT, you can eliminate a lot of normal or non-significant stenosis with cath. Okay. And this is one of the study was presented last year, I think from Denmark. Essentially, they did, I think for a period of time, 2 years, they do everybody who come to their center with suspected CAD, CT added with FFR derived by CT, showing that the outcome, patient who have if you have a CTA less than 70% by CTA and have a normal, not normal, the CTA FFR more than 80, more 0.8, the outcome is very similar to the patient who has less than 30% stenosis than a CTA. So what it means is that you could have a little bit more severe stenosis, no more than 70%. If you have a considered physiologically normal CT-FFR, the outcome is similar to those who has less degree of stenosis, okay? And the patient who had, this is, I think is a little controversial, is a patient who have abnormal CT-FFR less than 0.8, that tends to have less MI if they go to cath lab compared to the patient who does not go to the cath lab. I don't think they have enough number to claim that. Anyway, the point that I think they've done a very good job in funding a lot of study for clinical utilization. To the point is, I think the UK NICE also recommend that CT-derived FFR to be considered in patient who has CTA, and you need to know the functional significance. So again, I think they went very ahead of everyone else in recommending this approach. But point is, what's the caution, okay? Again, CT-derived FFR is not the same as invasive FFR, okay? The rejection rate is across the board is about 20%. Our case is probably around 20%. In other centers, it's a little bit less. In the European studies, they quote about 10-15%. You need to give nitrate, okay? So we cannot use in our TAVR protocol, right? Because we don't give nitrate in our TAVR protocol. If you have low contrast intensity, you have motion, calcification, severe calcification is problematic. They have some data showing that calcification doesn't affect too much. I'm not so sure that's the case. It cannot be used in patients with left main disease. It's not studied. Stent is excluded, and prior bypass. And turnaround time, I think, is no longer a big issue because really they've done a pretty good job. In a couple of hours, they give you the result, and the cost, I think, will come down eventually. This is one interesting thing that I'm going to throw in there in terms of using CTA as a management of patient with severe coronary disease. This is how the Europeans are pushing this. This is done by, I think, in Netherlands by Dr. Seres. You know, he's a guru of PCI. He did the syntax study. Essentially, they have patients who had, patients all have multivessel disease, need to go to bypass surgery, and they also have CTA. So they have a heart team of cardiology and surgeon review the CTA only and an invasive angiogram, okay? So essentially, if you include CT-FFR, at this stage, agreement in terms of what to do and what vessel to bypass between the CT only versus invasive angiogram only is about 80%. Meaning in 80% of those cases, there's perfect agreement in terms of number of vessel bypass graft that need to be put in. And I think they're doing a clinical study in Europe based on exclusively, basically they're getting rid of invasive angiogram. Okay, so there's going to be a clinical study just use patient with severe disease needing revascularization, decision made based on CT plus CT-FFR versus invasive angiogram only. So that's why I tell the fellows who want to go to interventional cardiology, you need, this will replace, eventually, I think, with better technology, probably will eventually replace invasive diagnostic angiogram, I should say. But regardless of what we do, I think this is, I don't think we pay too much attention to this paper. I think this is a very reasonable things for the fellow to read clinically because really give you some more balance and balanced view, and also give you some direction in what to do when you have when you read a coronary CTA. Okay, going from absence of coronary disease, when you read a study, okay, to minimal, mild, non-occlusive, moderate stenosis, severe stenosis, to total occlusion. I think it's quite balanced approach in terms of the management. Essentially, if you have no disease, minimal, non-obstructive, mild, non-obstructive disease, I mean, basically it's risk factor modification, moderate stenosis, depending on the symptom, you might consider functional assessment. If the study, I believe, if the study quality is good, CT-derived, FFR derived by CT, I believe is probably enough. You probably don't need to send the patient for a stress test. If the study quality is not so good, a lot of calcifications, some motion, patient have, the symptoms. I think at this stage, based on Pacific trial that I did not show, PET is probably the best next test to do. And obviously, if you have severe stenosis or total occlusion, I think the decision need to be based on clinical finding. I think I'm going to stop here, and before any question.
So Sumin, very nice talk. So it seems to me that the strength of CT is this calcium. That's also the weakness of CT, or that's the limitation, I guess, with CT when there's a high calcium burden. The question is, are there things that can be done from an acquisition standpoint to try to, I guess, figure out a way to work around the calcium issues, or is something
slow
like
heart rate. If you can get the heart rate to 50, I think, and unless a patient has a lot of, it's very big. I believe you have 50 heart rate, correct me if I'm wrong, my CT readers, I think, I would say most of the time calcium is least of the problem, but
why would a slow heart rate help reduce
because
the artifact?
calcium per se has this blooming artifact problem, but it's magnified exponentially by motion. Right? I mean, if you have a very dense object and it moves, basically make it uninterpretable almost sometimes. So if you have very slow heart rate, you can have frozen coronary. I mean, most of the time we can window, not from the acquisition standpoint, but from post-processing standpoint, we can get around and rearound, by rotating it, using different filter, reconstruction filter. And, and a lot of vendors working forever doing a calcium subtraction software, but I'm not so sure that's that accurate. Dr. M?
I guess the issue is this. I mean, with severe calcium, and Dr. Chang is absolutely right in that motion really destroys everything, because the partial volume effects, you're all familiar with what partial volume effects are. I mean, if you have some blooming artifact and you have motion, then that particular pixel is going to be counted, and you're going to be really unable to read anything. So motion it kills any reading if you have calcium. The other thing is, he's right that if you swivel around, you can do this, but if you have concentric calcification that goes around the entire vessel, there's no way to swivel out of it.
Correct.
And then you have partial volume effects that leave you, unable to know whether there's stenosis in the lumen or not.
Yeah.
And the other thing is, when you have motion on top of calcium, not only do you get blooming artifacts, you also get beam hardening artifacts. So you get these black areas that you can mistake for obstructive plaque, which really doesn't exist. So the bottom line is this: we do everything we can with calcium in terms of making sure there's no motion, in terms of coronary motion due to heart rate or patient motion for that matter, and also using sharp filters to try to eliminate some of the blooming artifacts that we see. But there are certain patients that are totally uninterpretable.
But you can see this case, I mean, fortunately, most of the coronary calcification are eccentric. Well, I mean, but yes, I mean, heart rate is the key. Even if you have the best scanner, like in terms of temporal resolution, we still want the heart rate to be nice and slow. What?
No, I just want to add that some vendors have tried, to answer Deepan's point, tried spectral imaging with coronaries and tried to image the patient throughout the energy beam. So from 70 all the way to 140, and then you try to come up with some subtraction, but it never made it to the real clinical arena. Plus your radiation dose, now it's going to go up much higher.
Yeah.
So spectral imaging, if you read about it in lectures and in textbooks, it has been utilized mostly in abdominal imaging and others, but has not made a huge difference in terms of cardiac.
For large vessel peripheral runoff, some of the studies I've seen really work, really almost looks like a digital subtraction angiogram when you get rid of, look like an MRA.
One thing I just want to mention is that you have to remember that the strength of CT is to exclude disease, not identify disease. Okay, so I mean that's why it's not indicated in people with known disease, because you really can't, in many respects, accurately read those kind of studies. And FFR doesn't work very well in people with known disease either, who have a lot of calcium, because that can also lead to errors in the FFR calculation. So it's really a test to exclude disease or find mild plaque that you wouldn't ordinarily be able to find. It's not a test to find, advanced disease. The only time it's worthwhile is when you want to specifically look at bypass grafts in terms of patency, or if you have specifically a stent that you want to be able to see if it's open or closed.
So the key for you to take home is the FFR derived from CT. Number one, again, is not the same as invasive FFR, and the most accuracy probably is somewhere less than PET in terms of predicting functional significance, less than PET, maybe close to SPEC probably, I think, from the data, from Pacific data. So let's make sure you understand that. And the strength of doing CT is you get both information. That allows you your accuracy to be a little bit higher when you have anatomy and FFR derived from CT. That's key for you to understand. So you have two information. Yes, Was?
I mean, to add for physiology versus anatomy, like a patient like this with CT FFR, so sometimes they are successful to give you a CT FFR, sometimes they're not, but even when they give you a number, they'll tell you that their accuracy drops down with the higher calcium score. So you have to look at it with significant caution. The other thing is that if there is minimal motion, then they'll try not to compute number. Like yesterday, we sent a case with really minimal motion, and they returned it saying that they cannot compute CT-FFR.
When I say the exclusion rate is overall, about 80% of the cases got accepted, but if you add some of the branches that didn't get computed, the number goes higher. That's one thing. The other thing is obviously the cutoff of 0.8 is arbitrary, right? Like invasive FFR. I mean, you're saying 0.79 is abnormal, 0.81 is normal. I mean, that doesn't make too much sense. So
And the other thing is that between 0.7 and 0.8, you might as well flip a coin
correct.
in terms of
Yeah.
whether it's real or not. And that's where most people sit. They don't sit at 0.5.
Yeah.
You know.
And also, a caution is if you have less than 0.7, most of the time, CTA is going to show severe stenosis. You probably don't need it. There's the cases I showed you earlier, critical stenosis, subtotal total occlusion. So real benefit, clinical utility, because all this premise is based on, okay, you have abnormal CTFR, and you need to go to cath and get a vascularization. But very important for you to understand that having an abnormal CTFFR or even an occluded vessel, depending on the location, you're not going to do anything if it's a distal RCA or distal OM, right? I mean, so the clinical utility, I think, need to be refined, but I don't think HeartFlow is going to fund those studies.
So maybe to sum it up between you and John, so which patient would you send to CT for fellows? Because once they get to practice, which patient you'll send to functional imaging? Because I assume even in the UK and even with the nice criteria, there are still some patients that are not going to be your best patients for CT. So yes, I mean, these kind of algorithms are nice, but technically you're not going to go with CT for everybody up front because there will be some limitations. So there have to be some sort of selection to which modality you're going to funnel patients.
I agree with that. If the low pretest likelihood, CTA is the way to go. I think nobody has. I think even I do clinic with Dr. Chamsi Pasha, and I got there, and then he was on the phone, and he said, patient had low pretest likelihood, we ordered a coronary CTA to exclude coronary disease. So So I think that most of the people agree with that. Um, I'm not so sure about the high pretest likelihood because, here, the Europeans say you do a functional test, but, from the ischemic trial, the design, they do CTA in everybody to exclude left main and three vessel disease. That's what we worry about. I'm not so sure what to do at this stage. Patients have, diabetic patients, 70 years old with chest pain and normal EKG, normal EF. I would like to hear what you guys say.
In my own feeling is, high-risk people, I usually don't send for CTA. And I mean, if it turns out that someone's and they send them for a functional test, I usually then like to get a calcium score if it's normal and be able to see how much plaque they have. But I don't usually send high risk. I tell you, most of the time I send people that are either low or intermediate risk who I think have atypical symptoms where they're not going to be abnormal, or I send them for people who have actually had functional tests where they've been equivocal, either treadmills or whatever, where I think probably the treadmill or the nuclear study was just due to artifacts or whatever, and I'll get CTAs in those people,
I think maybe ideally.
As a first, as a second test,
Ideally, I think we probably could do a exercise PET, which you can have functional information and flow information. In that case, even patients at high risk, you probably have very high confidence that a normal perfusion, a normal functional class, and normal flow, the likelihood to have severe left main or proximal AD severe disease is very low. In that case, I'll probably sleep better without getting anatomical information.
I agree with this approach. I think the key point here is you're still going to assess the overall risk of the patient, even though these algorithms that you see mostly from the UK. So just to give the fellows some background, how was the UK NICE guidelines developed? Where did they come from? Like, how did they develop them and who developed them? It was mostly non-physicians. It's a NICE. NICE is like Medicare here. It's the one that kind of fund NHS. They come to them with the NICE guidelines. So it's mostly guidelines. And it's mostly healthcare economics that sat down. The committee that came up with these guidelines sat down and did the pretest likelihood. Because now we're testing so much low-risk patients. So if you take everybody coming to our non-invasive lab, the chance of having a normal study is very high. It's as high as 90% in some labs. So they said, okay, well, if we get a CT on them, a CT costs much, much less than other modalities, then we're going to be fine financially because these people are going to put guidelines so they keep the NHS even. And then they went ahead and said, well, since we're going to start with all of these CT for everyone, and then those that CT cannot answer will go and do another test, then this is important for them to save money from that aspect. So a lot of it was mostly economics driven there. So clinically, potentially, I mean, I don't think that the answer is going to be pushing so much functional imaging in a very low risk population. I still think in this population, anatomical testing is going to be very helpful as long as you're not going to go the route of artifacts and additional testing. You want to order a test that will be the last test. We don't want to have layered testing. Layered testing is not good for patients because it will expose them to more radiation, more procedures, more financial costs, and more potential for false positives and others. So we want to order the test that will be the last test. If you truly believe that the patient's symptoms are very ischemic, and you probably just go to cath. If you very much think you have positive EKGs and the patient had multiple risk factors and high risk. So you don't want to do a nuclear, then do a CT, then do a cath, like what you see sometimes happening in practice for different reasons. So I think the point here is that many of these guidelines are driven by cost and others because simply the cost of CT is much, much lower than other modalities. So it's going to beat any other any other modality that you're going to put it against it because of its high negative predictive value and low cost. So, but still you're going to apply your clinical judgment, as Dr. Mamarian mentioned, in clinical practice. If you see someone that is likely to get an artifact, or open up if there is a chest CT in the EPIC, if the patient had the chest CT for PE and you see rocks of calcium in the arteries, even there is motion, you can still identify calcium. Don't order a cardiac CT. When you are rounding, many of our patients had a CT PE before they made it to the ward. Open up the chest CT. That's the reality, right? I mean, you're laughing, but how often do they got a chest CT PE before you come to them? Look in the corners. If there is a lot of calcium and the patient's symptoms are clear, then either functional testing or cath directly. If the patient doesn't have calcium and you truly believe that the symptoms are not concerning, then you may just stop there or may potentially just get a CTA. So there are things that you need to tweak while you're making your clinical decision for which modality to make up the route of anatomy versus function versus other image versus nothing even.
Yeah, and just one of the last point, if you look at the meta-analysis data in terms of CT, in terms of events, what CT best predicts is revascularization. And that's because most of the people who get CTs are low to intermediate risk to begin with, so they don't die right away from cardiac disease unless you follow them for a long time. They don't die from MI. But what CT does predict is who gets revascularized, and that was actually shown in PROMISE too. Also, because I mean there was twice as much revascularization and no difference in hard cardiac outcomes. So we have to be prudent about how we do things and how we analyze data and look at a patient.
And obviously, for the fellows who were trained here, we have the best scanner in terms of temporal resolution. But I don't think how many centers in the U.S. has actual dual force scanner. So very likely, we go out there, most likely you're gonna not have access to the premium, last generation scanner. So bear in mind that also when you order the test, right? If you have a old Toshiba 320 scanner, I mean, with the temporal resolution of what, 280 or 290, I mean, you want to make sure your heart rate is nice and slow and that there's not much calcium before you order the CTA. Yeah. Okay.